physical therapy. This is Courtney Page, and obviously we are very excited to have you guys here. We appreciate you guys taking time out of your evening to come spend with us. Hopefully it's worth your time. Some of you may have been needled. Some of you may have seen needling. Some of you may have watched videos on needling, or some of you might not have any idea what needling is all about. But regardless of how much you know, we're excited to have you here. This is going to be a pretty informal setting, so if you guys have questions along the way, just type out, shout, throw something at us, kick a hand up, whatever you like to do. We kind of broke it up in 3 different sections that you guys will kind of see from that outline there. So Courtney's going to start off talking about trigger points, just kind of what trigger points are, different ways that you can treat them, and give you a little bit of explanation behind some of those ways. Then Paige is going to take over and go a little bit through what dry needling is, kind of the theory behind that. And then I'm going to take over the PT side of things, so kind of how we use dry needling in our practice. I'm going to give you a few case studies of people that I've used it on and seen some benefits with, and then we're going to do a demonstration on it as well. So if anybody has a dire need to be needled, then tonight would be a good night to kind of pipe up. So we'll do that as well. We do have some online audience today, so you guys have questions along the way. Make sure you type those in, and Nate can pipe up and ask those. At the end, we'll do a little Q&A session before we do some demonstration stuff as well. So, Court, take it over, my lady.
Okay. So to understand what dry needling is, if it would be beneficial for you, and who it would be beneficial for, we need to briefly kind of touch base on the anatomy. Before you all glaze over, we'll make it very brief. So I'm going to go over the anatomy of the muscle tissue, trigger points, what they are, their symptoms, and what could potentially cause these dysfunctions. So we'll jump right into the anatomy. There are approximately 400 different muscles within the human body, and any one of these can develop a trigger point. I've seen a patient with some TMJ stuff that has a trigger point in their masseter, or their muscle that does the chewing, all the way down to like the feet. Someone who has plantar fasciitis or has trigger points through the muscles on the bottom of their feet. So head to toe, you can develop a trigger point basically anywhere. So if you look at the first picture on the handout, I'm going to go over muscle tissue. So there's different layers of the muscle tissue. In each of your groups, like your bicep, your hamstring, your calf, if you break that down even further, the smallest kind of portion of that is the muscle fibers. And these align kind of in a parallel fashion. When you shorten your muscle, they contract. When you elongate them, they relax. So a whole bunch of these tiny muscle fibers make up fascicles. And then groups of these fascicles make up the larger muscle. So around each of the fascicles, there's a connective tissue sheath. And then around the larger group of muscles, there's a connective tissue sheath around that as well. The sheaths around the smaller fascicles, they're important because they're what conduct the nerve. So to get the contraction, that has to send a signal from your brain to get the contraction. And then it also provides blood flow, oxygen, and nutrients to the muscle tissue. The sheaths around the larger muscle are called fascia, and this is important when you have your muscle contraction. It generates the tension from the muscle to the other muscles. It also helps reduce friction and rubbing as those muscles are contracting. So what does all this have to do with trigger points? Trigger points are considered to be hyper-irritable spots, either in the fascia or the muscle fibers themselves. So if it's in the fascia doesn't actually contract or shorten. Usually they're like some type of adhesion or fibrosis or some kind of scar tissue that's built up over time. Christy's like, yeah.
And that's like, a lot of times you hear IT band syndrome, and people talk about stretching the IT band. IT band is kind of what she's talking about there. That is a type of fascia that runs down the side of the leg. So I always describe that as being like spider web type material. It doesn't actually shorten and relax, but it can adhere down to that lateral quad muscle. And so that's what we're kind of working on when we're working through the IT band.
And so you can get trigger points there, or you can have trigger points through the muscle tissue itself, where the muscle fibers that need to shorten and elongate like they normally do, if you overwork your muscle or you kind of repetitively use it too much, your body lays down more tissue to kind of help build it back up. In reality, it's laying down too much to kind of make up for what you're doing. This can create some tightness or tension where normally it sits like this. It has a little bit more kind of a thickened. So in order for it to shorten, it really can't shorten. And then the other tissue on the either end of it is elongated because this is already pulling on it. So you can see where that would create some problems as the muscle is trying to shorten. So normal, healthy muscle muscles. They don't have knots. They are not tender to touch with pressure. And when relaxed, they should be kind of pliable and soft. And a muscle with a trigger point, there's different symptoms depending on the person, how long they've had that kind of muscle tension. Some of them may include pain or tenderness when you're kind of pushing through. So if you had one through, like, let's say your upper trap, if you're kind of pushing through there and you find something kind of tender or painful, it can be localized just to where you're pressing. Or another example, I have a patient right now, we're working a lot through her rotator cuff, strengthening that. And she has a trigger point kind of through the backside of her shoulder. As I push through there and kind of work on releasing it, she feels pain all the way down into her elbow and sometimes through her forearm. So you can get referred pain with them too. You can possibly have like a local twitch as you're kind of pushing through there, where it might create kind of a small muscle spasm. You can have weakness or loss of coordination with that muscle contraction. You can have limited range of motion. Your muscles might fatigue more easily, and then your muscles will have kind of a harder time returning to its normal relaxed state. So what causes these trigger points? The bad news is everyone gets them. They've done some different research. They found that some women might be more predisposed to getting trigger points, but no one's exempt from getting them. There are some things that cause them or kind of make you more susceptible to them. It could be from muscle strain, from overuse, like a repetitive type injury, or from like a weakness type injury. So an example, like if you were painting one day and you did a lot of kind of arm movements painting and you really kind of stressed your shoulder, and that's not normally something you do, you can develop like a trigger point from your shoulder being too weak or from that overuse of that. Some other causes could be poor posture. If you're sitting like this throughout the day, that's elongating the muscles.
Everybody sit up.
That's elongating the muscles on the back, so it's not keeping that muscle in an optimal position for that contraction. Poor flexibility through your tissues, nutritional deficiencies, different metabolic disorders like hypothyroidism or hypoglycemia, dehydration, stress, or even poor recovery after increased activity or working out. So let's go over a couple different types of treatments for these trigger points. We at True PT use kind of a wide variety of modalities to treat things. I'm going to go over 3 that we kind of all use, and then Phil kind of dive into the trigger points. So that way we can kind of compare and contrast them. So a successful treatment involves locating the trigger point, treating the tissue, and then addressing the root cause, whether that be a strength issue, posture issue, or maybe just some life stressors. The first one we use is we call it here instrument-assisted soft tissue mobilization. So that's kind of a large mouthful. Other clinics might call it Graston technique or A-stem. So basically, what these techniques all kind of do is they use some type of tool, whether it be metal or plastic, that helps kind of break down the scar tissue, any restrictions, the fibroids, or even with inflammation. But let's say like we have someone with tendonitis of the elbow. We would use kind of a massage cream. We have plastic tools here. We would work through the tendons and the muscle belly to have kind of a controlled microtrauma, and that would help stimulate like a localized response to help regenerate the tissue in a more kind of normal fashion. Afterwards, it's pretty typical to experience soreness, like a bruise type feeling, or have some redness through the area. The second one that we use pretty commonly is called self-myofascial release. That's basically a fancy term for self-massage. So we do that a couple ways here. We use a foam roller, where you've seen like these long tubes kind of sitting behind us to kind of work through the area, or we even have like a rolling pin type thing called a stick where we can roll through different muscles. But this technique helps break up the tight muscles and the different knots. The science behind this is that deep compression helps kind of reset the muscle, provides it with more blood flow to the area, and helps kind of break up any adhesions between the layers of the muscles and the fascia. The third technique is we use a trigger point release. If we are personally doing that on a patient, we'll generally kind of like use our hands to kind of search through the muscle belly to find any tight, tender areas, and then from there we'll do kind of a prolonged, deep hold, depending on how tight it is or how sensitive. The science behind that is also very similar to the foam rolling. The deep compression helps the muscle relax, resets it, provides increased blood flow to the area. At home, if you were doing that, you could do it with like a tennis ball or a lacrosse ball or something to help kind of provide that deep pressure. common. They are not the most comfortable. They're a little bit painful. And so I kind of get this common question, like, why would I do something that's so painful to help me feel better? And the analogy I like to use is a bungee cord. So if I were to tie a knot in the bungee cord, I could stretch that bungee cord and elongate it much like you would elongate your muscle tissue. But that stretching or elongation alone won't have any effect on the knot itself. So you have to do something like one of these modalities or like a dry needling to help kind of address that knot to get the tissue to return to its normal kind of elongation state. So any questions over trigger points or the anatomy behind the muscle tissue or kind of any of the three first techniques I discussed? Okay.
That's a good
We'll send it on
information.
over to Paige.
Yeah. I think one thing just to kind of emphasize with that, and I don't know if you had something as well, but so oftentimes people are like, how does it hurt down here if my trigger point is here? And that was one of the things that we really learned at our dry needling course. And I have a book that kind of shows some mapping of trigger points that's really interesting because what they did was they did a study where they injected trigger points and then mapped out where people felt the pain when they injected those trigger points. And it's really, really interesting to see that. So oftentimes the pain is not where the injection actually occurred, but it is where that referral pain is. For instance, the glute min, that's one that I always think is really interesting. So that's a muscle through your rear. Most of the pain that you have with that when you get that trigger point is actually down the side of the leg. It can even extend down the side of the knee. And nobody that they tested in this study had pain where the injection was actually taking place. So it's really interesting to kind of understand that and know that trigger points are a really powerful thing. It doesn't mean that you're going to have pain right there. You might have some pain that refers in a completely different location. So I think that's an interesting fact.
Yeah, and that study too, it's important to note that study had hundreds of people in it. That was not a study of like 10 people.
Right.
I mean, it was a really big study, well published, well accepted. So they basically, they know that's how it works.
Yeah, absolutely.
Court kind of talked on, what a trigger point is. I'm going to talk a little bit more about the theory behind functional dry needling, which is what we do here in the clinic. It's based on a couple different models, and I struggled. I was telling Julie when I put this together, not getting too scientific. But do know if you guys have any questions, be like, hey, talk a little more about that. I'd be happy to go into more depth, but I'm just going to kind of, summarize some of these long articles.
We don't
for
need guys
you here.
snoozing.
Yeah, no sleeping. So anyway, the first model is the trigger point model, and it kind of talks about how these trigger points come to be. There's some sort of injury to the muscle, where overuse, improper use, overstretching, or overdemand on the muscle. That causes a release of some different substances into the bloodstream that are needed for contraction. What happens then is you get an overcontraction of that localized area. Not necessarily the whole muscle, but just where that substance has been released. It causes a prolonged shortening of the muscle. By doing that, you get a slight, not completely cutting off blood flow, but you are providing some compression to the area. When that happens, the body isn't able to provide the needed nutrients to the muscle. It isn't able to take away waste product. You kind of get this prolonged inability to heal and self-correct in that particular area. That also can cause, those accumulation of substances can cause hyperirritability and hypersensitivity of the nerves in those areas. That's why it's so painful just in that one spot. Not always, is the whole muscle, it doesn't hurt down here, it just hurts right here. Those are the nerves that have become hypersensitive. That then, they've done a bunch of studies on kind of what the muscular changes are in that area, and they've seen a bunch of things. They know there are certain characteristics of those muscles. They're more prone to twitching, they're painful, they don't like compression. I think it's important to note, though, that there are a couple different kinds of trigger points. There's an active trigger point where I push on it, it hurts, that's my pain. There's also something called a latent trigger point where, I didn't even know that was tender, but yeah, now that you push on it, that is uncomfortable. And then there's also trigger points where we feel knots in the muscle, but they're not necessarily causing you pain at that time. Those are different types of trigger points, and so just because, when we're working on you, that's not your pain, that doesn't necessarily mean that's not a trigger point. So then the second kind of theory behind some different ideas of trigger points is called the radiculopathic model. And this one has a little bit more to do with kind of the nerve component of it rather than just the muscle component of it. The idea here is something has happened to the nerve that innervates those muscles. Something has caused some kind of irritation somewhere up the line from where it exits your spine. Then, by that happening, all of the nerves and all of the muscles innervated by those nerves down the chain become affected. A lot of times you see what they saw in the study was a heightened sensitivity. They were more irritable. People were more sensitive to pain in that area. They also saw banding of muscle tissue, meaning they saw trigger points in that segment. Those caused excess strain, and it kind of became this vicious cycle related to that nerve distribution. Then you start having poor mechanics, and it just kind of turns into one after the other. So functional dry needling takes into account both of those models, the trigger point, but also kind of the spinal segment that corresponds to those muscles that are having the trigger points in them. Any questions over those two models? We're all good about, I don't know, that leads us right into, okay, so how do we use this? What do we use this for? It's fairly self-explanatory. What are the things that trigger points cause? Pain. So that's one of the reasons that we'll do it. You're having pain in a muscle or area, or maybe a referred area. Like we talked about, they have their own referral patterns, so we, are trained to kind of recognize that. A lot of times Julie will bring out her book and, we'll show you, look, see, there's your pain, So the idea there is that we're creating a change in that muscle and helping the body regenerate so the spinal segment, those nerves don't have to be so sensitive. They lower what the studies call the pain pressure threshold. You're able to tolerate more compression, more stimulation, and you don't perceive that as painful anymore. Another thing that we use it for is weakness. So I think people are pretty familiar with like radiating pain, or they say, oh, the pain coming from my back. Those nerve fibers don't just carry pain, they also carry signals for the muscles to be able to fire. So when we test you, when we evaluate you, we will look at that as, okay, are you having kind of a pattern of weakness in these muscles that are coming from that same spinal segment? We can use needling then to treat the spinal segment. So a lot of times we will needle close to the spine, the muscles surrounding the spine, and those stabilizers, and then also the muscles down the chain that are producing weakness. Those are important to do together. So that's another thing we use it for. And then probably one, I would say probably the most common, what we think of needling for is to increase tissue mobility, to give you better range of motion. Courtney's, I loved that example of the bungee cord. I was like, that's a really great picture to create, because I think that's what most people expect. It's important, though, to realize when we're talking about increases in mobility, these fibers are nanometers. They're tiny, tiny, tiny things. So, yes, sometimes we see this 10-degree jump in range of motion, but other times it takes a while, and it takes multiple sessions to see a good, true lengthening of the muscle, because you're working, like she said, each muscle fiber, each fascicle, each muscle band has to lengthen as well. The idea behind needling, the functional dry needling, is that it is to be used in conjunction with all of the other things that we do in PT. It is very rarely used as a standalone treatment. It makes all of the other areas that a PT is trained in, how to treat muscle dysfunction, how to treat movement dysfunction, more effective. Okay, and it gives you a little more bang for your buck, essentially. Now, that being said, there are some situations where we aren't able to, even though it's a great tool and it does make things more effective, there are some contraindications, meaning we would not needle you. Those are listed there: pregnancy, uncontrolled blood thinner use. I have people ask me all the time, well, I take a baby aspirin. Well, have you taken a baby aspirin for years and years? Yeah. Have they changed your dose of the baby aspirin? No. Okay, well, that's considered a controlled use. You're safe in that situation. But if you are, at risk for DVTs, or you're going in to have your blood, your INRs, maybe you've heard of that. If you're having that monitored and they're changing, we're gonna call your doctor. we're gonna want to do a little bit of investigation before we needle, because we are, penetrating the muscle belly with a needle. There is a risk of bleeding there. Okay. People who are immunocompromised or immunosuppressed. Basically, we're talking about people with cancer, active cancers, or some kind of autoimmune disease that makes them more susceptible to large infections. We are introducing a foreign body into your body. There is while very, very small, we practice clean needle technique. The needles are sterile. There is a risk of that, and that's something that we decide kind of on an individual basis, obviously working interprofessionally with physicians and primary care providers to make sure that it's safe. Safety is always the biggest concern. A true needle phobia. So we talked about this a little bit in class. I don't know anybody that's like, ooh, yay, needles. But if we've spoken to you about this a few times and you have a legitimate fear, you are not comfortable with it, it is not something that you are willing to work through. If you have some kind of response every time you see a needle, your blood pressure goes through the roof, that may not, the cost-benefit ratio may not be in your favor in that situation. But we have lots of people who, aren't the most comfortable with needles, don't love needles, and they do great with it. We work at your pace. We're not.
How deep do these needles go in your body?
It depends on which muscle we're needling. It depends on the trigger point. So some of them are pretty deep. They can be. Other ones are pretty superficial. Most of the time I ask people if they feel uncomfortable, just go ahead and turn away, and then if you get all curious at the end, I'll show you how big of a needle it was. But usually,
or you have a patient like one of mine who I was needling her glutes, and I stepped out for a second, came right back in, and she's laughing, and I'm like, what are you doing? She's like, I was videotaping it. She's laying on her belly, has her phone up, and she's like, look, I can show my husband. She's like, I just wanted to see it, and I couldn't get a big view.
Well, and see, I have a patient that had a pretty serious fear of needles, really did not enjoy them. She was fairly apprehensive about it, so she did not watch. And then afterwards, she goes, okay, let me see how big the needle is. And I showed her, and she was like, oh, that was in me, and I didn't freak out.
Yeah, exactly. Go me, pat yourself on the
It
back.
was like she got rid of her needle fear.
Yeah.
Anyway, the other ones, the last two. So if you've had surgery, we cannot needle the area that directly, for example, knee replacement. We could not needle a muscle that directly communicates with the knee, above or below, for 12 weeks post-surgery. We can needle somewhere else, though, in the leg that doesn't communicate with the knee after 6 weeks. So say like your glutes or something like that. We could do that at 6 weeks, but we couldn't do like your calf muscle or your quads for 12 weeks after your surgery. And there again, we're, always asking doctors, and, it's not that hard to call somebody or shoot an email and make sure. we use it, when we wouldn't use it, or just kind of the more in-depth scientific theory behind why it's effective.
Well, I'm curious to know how long it lasts,
The benefits or the procedure itself?
Yeah,
the benefits.
Okay.
it's an individual basis. So most of the time, I don't think I've ever done. Have you ever needled somebody and said, all right, you're golden?
Like, and not done anything else?
Yeah.
No.
And that's not the way we were taught. So you needle them and then you give them corrective exercises afterwards. What I would say is it depends on how good you were about doing the correctives. It depends on how bad the tissue dysfunction was.
The chronicity of the issue, whether it's something that's more acute. I mean, just to give you some like specific examples, I had a patient who had some kind of strange anterior tib insertional pain, like right on the top of his foot, and it was waking him up at night, which is kind of a rare situation. And I had done a couple different things, I mean, quite a few different things, treatment-wise, to affect it. And I needled him, and after the first time I needled him, he had 2 days pain-free where he didn't wake up at night at all. But then the pain started again, so that was 2 days. The next time I needled him as a circuit, like what she was talking about, where I needled the level of spine and the muscle that was affected. And he had 3 days, no pain, 3 nights. But I saw him then, and so he hadn't had pain since I saw him. So I don't know, like after that, how much more. So it's really variable. You know, we've been doing this for 2 months, so not a long time, and we don't have a whole lot of things to base it off of. But I mean, you can get a pretty quick response where you notice immediate changes and it's long lasting, or they may say, you know, especially if you're not doing those corrective exercises, that, yeah, it helped right away, but then I woke up the next morning and I still had some stiffness, or I decreased my motion a little bit, or something like that,
I
too.
think something else to really go along with that is it depends on kind of the whole, you know, as PTs, we always look at your whole body.
Yeah.
So I've had a patient that I needled where when I evaluated him, he had hip pain. He had intense limiting hip pain. He was a swimmer. We did a bunch of things. We tried some different things. Really was not improving. He was a pretty high-level athlete. I needled him one time, gave him several corrective things. He was very diligent about it, and he was essentially pain-free. He only had that one thing. He was strong. His motion was great. I literally could not get this kid to fail a test. That was his only issue. I also have someone that I've needled multiple times. She has a lot going on. Yes, her neck hurts.
Yeah.
But she has, you know, low back problems. She has arm weakness. She has core deficits. There's a lot more playing into her situation. So she got relief for, you know, a couple days after each session, but we're still addressing all of those things that are probably really the root of what's causing her trigger points.
Absolutely.
What is the difference with what you're describing in acupuncture?
Yeah.
I'm sure you get that question.
Yeah, we get that all the time. The only thing that's the same as acupuncture and dry needling is the needle. The size of the needle is just like an acupuncture needle. Other than that, really the philosophy behind why you're using the needle is much different. So with acupuncture, and I'm not an acupuncturist, so I'm not a specialist in that by any means, but what they are doing is they're looking more at energy flow. So meridians and how your body is, you know, how the energy is flowing throughout your body, and then they are putting needles in certain spots to affect that. With the dry needling, we're affecting all the things that Courtney and Paige just got done talking about in terms of neuromuscular. We are finding the tight spot in the muscle and addressing, you know, that muscle tension with the needle. So it's much more of a neuromuscular model versus more of that, like, energy flow.
And based more from, like, just a patient's perspective, there are a couple acupuncture techniques where the muscle belly is penetrated, but for the most part, the needles stay in the skin and just right below the skin. In dry needling, we are looking to affect the muscle.
Yeah.
We need to penetrate the muscle.
Yeah.
You
So-
never put anybody to sleep to do that?
What?
No.
What'd you say? What'd you say?
She asked if we ever have to put anybody to sleep to do that.
I said, would you?
Oh, no. No, probably not.
Acupuncture, Dr. Myers said it, because I've had that and it works for a year.
Yeah.
For a year. It wakes up those, what do you call those things that rush to kill pain?
The,
Nociceptors or?
well, the kind of endorphins.
Endorphins,
Yeah.
It wakes up the endorphins, shoots them over there, kills the pain. That's what acupuncture does, basically.
Yeah, and so it's
In
really
layman's
important to understand. When we took the class, I would say at least a quarter of the class was also certified in acupuncture. They performed both.
Yeah.
So it's not like competing models. We don't think that acupuncture is wrong. Like I said, those people did both. They were now certified in both. Different ideas, different philosophies, probably different situations.
Well, basically,
find
acupuncture treats the pain and gets rid of that pain level. What you're doing gets rid of the problem.
Yeah. So, yeah, and I think it probably, like I said, we aren't acupuncture specialists, so it'd be hard to say exactly, yes, you are getting that endorphin release. But I don't know if, I think there's probably more than that to what they're.
Well, what he did to me, that's pretty much it.
Why is it called dry needling?
Because it doesn't hold any type of fluid that you're injecting into the body. So it's not like a, flu shot or a vaccination or something
There is
like
a
that.
thing called wet needling, where they do inject a substance into the muscle belly. But that is not what we're doing. Botox would actually be a form of wet needling, yes. When used for things like spasticity.
Does age come into play? I'm right up to that top end of age. And,
Are you sure?
Yeah, I'm pretty sure. And I didn't know if that is the minus to be, because I'm pushing 80 and very close, and I didn't know if that was a problem.
I would say not necessarily, I would say no. I mean, I have needled people over the age of 80, so that doesn't necessarily mean that once you hit a certain age, you're just like lost cause, because there is definitely a lot that can be done there. Now, there's changes as you get older, your blood flow is different, your muscle tension is different, recovery is different, healing is different. There's so many different things to take into consideration. So, looking at the benefits of it, it may be different, as you get older. I don't necessarily know that there's any kind of research to prove that, but I would still, without a doubt, do needling on a patient that was older, regardless, of their age. I wouldn't say, you're not a candidate for it because you're a certain age.
I think I would base my clinical decision on whether to needle someone who's older based on could they do the corrective exercise afterwards. I have the exercise in mind that I want you to be able to do. Are you going to be able to perform it effectively enough? If I feel like no, well, then.
And even with that, I mean, there's a lot of different modifications that you can do for exercises. I mean, there's not one specific exercise that's good for somebody after needling a certain muscle, I needle the same muscle on 3 different people and give them 3 different things to do based on their limitations too. So, and we can always make modifications there, but yeah, absolutely. I think, definitely, really, I would have more concern about needling somebody younger just because of the fear of needling and the experience with that. I've needled, I think a freshman in high school is the youngest person I've needled so far, and I think they normally said 12 or above is kind of what they shoot for. And then make sure you look really pretty and do everything perfect because you're going to be on social media. Facebook, here we go.
Yeah, and they said 12 mainly because they felt like that was about the age where the child or individual could really fully understand kind of what was going on. And I guess that plays into age as well. I mean, you always want to make sure that you're giving good informed consent and people fully understand what they're doing.
Right. Okie dokie. I'm going to talk a little bit. I just thought of some stuff as they were talking, and so I get all excited and I start going off on the lower So I'm just going to explain a little bit because I don't think we really have. And I don't know, how many of you have seen needling done? Anybody? Okay. So I'm just going to talk a little bit about, what it actually is, what we do. Are we bringing in, this huge sledgehammer size thing, or what are we doing here? So Basically, she talked a little bit about how we're looking for tension in the muscle, depending on what we're trying to get out of it, and most of the time that is what we're trying to do. We're trying to find tension trigger points in the muscle to address. There are also some patients that I use it for just for muscular dysfunction, meaning the muscle's not contracting the way that I want it to, so I'm needling it to get it to respond better. So typically, no, you're good.
That's kind of what I get with the latent trigger points.
Yeah.
They're not pain generating at this time. That doesn't mean that there isn't dysfunction in that tissue.
Right, so what we'll do is we use gloves, we sanitize, we clean the area with alcohol. We have needles of various sizes depending on how far we're trying to get into the tissue, depending on what muscle. So kind of like what you asked there. We will needle the erector spinae where they insert in the back of the occiput. That's like right underneath the skin, so you're hardly going in at all. I mean, I get to use a teeny tiny needle and I'm there. But at the same time, we'll needle the glute min, which is really deep, depending on the size of the person, depending on the size of the muscle, and then the needle is much bigger. So we penetrate the muscle with the needle. Typically, the first pass is a very slow pass where we're just assessing the tissue. So we will feel a difference in what the density of the tissue feels like as we're inserting the needle. So if you hit a trigger point, typically you can feel that it's a little bit tighter. So you go real slow. Make sure the patient doesn't have any, ill responses to either the needling or have any pain that we don't perceive as being normal. Also, there's superficial veins, superficial nerves, superficial arteries that you can hurt and that you can hit. Obviously, we are always assessing where the big, like the sciatic nerve is and where, big things like that. So we're staying clear of those things. But sometimes it bleeds just a little bit, and that's because we hit a superficial vein and you have a little bit of bleeding. It's a dot of blood. It's not like, profusely shooting out of the arm. But we're assessing that to make sure. Right, no. So we're assessing that to say, okay, that was a good clear pass. I'm exactly where I want to be. The patient had no ill responses to it. They're doing well. Depending on either the muscle, the patient, kind of how we feel like things are going, we may do a little pistoning of the needle. And what that means is we're moving the needle up and down. We're not moving it around all over the place. Up and down in the same track that we were just in when we inserted it on that slow pass. And what we're looking for with that, and the reason we do that, is we're looking for a response of that muscle. What are you doing shaking over there? You're like getting the EBGBs, me talking about it. Yes.
Well, I was just wondering, did you guys get needled when you were taking this class?
50 times in a weekend.
Yeah.
Like within 3 days, we were needled on every single spot that we learned how to needle multiple times. So we got done and we were like, okay, I think I've been needled enough for a few days. So then we do a little bit of pistoning sometimes, depending on how the patient is responding. And we're looking for a spontaneous electrical activity or a twitch response of that muscle, which is actually a really good thing.
That's the best response.
That is the best.
That is the best outcome we can ask for.
Because the muscle is responding to what we're doing. At that point, sometimes we take the needle out, and that's it. It takes a total of 10, 20 seconds to do. Sometimes, and most of the time, with what I've done so far anyways, we do a form of electrical stimulation with the needle. So we actually hook it up to electrical stimulation to get the muscle to fire. And it feels like a heartbeat, so it is a good, just rhythmic contraction that you'll get of that muscle. That just shows the muscle's responding, and we're changing the function of the muscle. We look for changes in that, how rhythmic that contraction is as the needling is going on or as the e-stim is going on. So I might do it for a total of 2 or 3 minutes. And at the beginning, that rhythm is not, very regular, so it's kind of all over the place, or they're not getting hardly any of the contraction. And then after 2 or 3 minutes, it's real nice, rhythmic beat. They have change in symptoms. They don't feel it as much. The muscle contraction has changed and gotten a lot better. That's when we know needling is over, we're done, we take it out, and that's the end of it. We can do 1 needle at a time. We can do 2, 3, 4. We can do 6 needles if we wanted to. I've never done that, but there are some patients that literally, they don't care. They feel like, yeah, just do as many as you can at one time and let's knock it out. And we can set them up on electrical stimulation. We have alligator clips that we clip onto the needles. And we can set them up on it for 8 minutes, 10 minutes. They said as far as 20 minutes sometimes. Other times it's 30 seconds. So it just depends on the patient's response. What was that?
It doesn't like move around?
No, not at all. And we're not getting, I mean, it's not like, oh, my arm's flexing every time, but you'll see.
It's more, it's like a twitch. It really is a twitch, and it's not this massive muscle contraction. It's important to understand too. It's just that muscle. It's not,
I'm just more concerned about how the needle hurts going in.
I would say most people, they feel a little prick. This is what I'll tell you. This is how I felt it. This is what I would say most people feel. You feel the prick of the needle go in. It's a small needle, but you will feel sometimes a prick. As it passes through the soft tissue and fascia, usually most people don't feel anything. They don't feel it at all.
Well, because I had a nerve test.
Mm-hmm.
Okay, they got to a point I said quit.
No, this is
Nothing
not
like that.
Not
Not at all like
Okay.
that.
No.
Much different. And, I mean, yeah, they are trying to hit the nerve to see
They're
what
trying
happens.
to hit
Yeah,
the
we are
nerve.
staying away from it.
Yes.
We are working on just the muscle.
Well, it was fine till they got into here.
Yeah,
Okay, that,
yeah, not at all
we
like
quit.
that.
I
No.
don't
To
like
put it in
that.
perspective, I'm kind of a baby with needles, and when they got back, they're like,
Oh.
let's needle something, and he was like, okay. And like the big thing, like when it went in, as soon as I realized I was tensing and I relaxed, I was like, oh, that didn't even hurt. So I felt some pressure in the area. My muscle was so tight where she did needle my hip that I felt just some mild achiness, but I never felt like the actual like one pinprick, like a
Okay.
flu shot type needle.
This
It was just
this
very
needle-
mild.
So most needles are, like a 20 gauge, I believe, needle that you get like an injection with.
Mhm.
This is so much smaller than that. Like it is a very fine, thin needle.
Yeah.
Um,
The get bends just super easy.
yeah,
So especially just the skin prick that hurts, if the inside it doesn't,
Yeah.
is what you're saying?
Yeah, it depends. I mean, people will notice, and everyone responds differently. I mean, I have patients that I put the needle in, and they're like, "Is it in?"
feel it all.
Like, I didn't
Yeah.
even know. Versus there was other patients, like, especially when I've hit some good trigger points, that they're like, "Oh my, like that's my pain." I did a patient last week where I found a trigger point on the lateral quad, and when I inserted it, I hit the trigger point, and I was like, "That's firm." I could tell immediately that that was a good trigger point, and I said, "How you doing?" She said, "I'm fine." We inserted it into the trigger point, and she had a reproduction of her anterior knee pain, exactly where she was like, "That's my pain." And then, of course, she's like, "Well, let's keep doing this." Like, yeah, it hurts, and I don't like it, but I know, I'm going to get a good response. And then, I saw her 5 days later, and she was playing tennis, and she hadn't had any of that pain since then. So it's really cool to see the response, but everyone is different,
Everyone is different, and I think it's important to say what kind of discomfort, or,
Yeah.
we're saying pain, I would say it's a discomfort.
Yeah.
I don't know that I would use the word pain.
Mhm.
It's an achy pain.
Yeah.
It's like a crampy achy. It should never feel sharp or stinging or shooting or stabbing or burning. Those are not normal responses. If you get any of that, we move the needle. We redirect away from that. And I would say 100% of the time, every time that's even occurred, there's, oh no, it's fine now. So it's a type. It is can be uncomfortable, but it's not this like, ice pick in the leg pain. It's a ache.
That was ice pick.
Yes.
It's a beautiful
Yes.
analogy. It was very morbid picture. Her face said ice pick.
I know. I saw her getting the EBGBs over there when I was talking about it. I was like, it's really under there.
So I want to elaborate on the twitch response a little bit, because I kind of talked about it, but then I realized I think I kind of overshot there when I went into the theory. So the reason we want a twitch response, the idea there, I talked all about what's happening at the muscle belly. We want to stimulate a contraction in that area to reset the muscle tissue, to increase blood flow to the area, to basically use up that calcium and the different biochemicals that the muscle needs to contract. We stimulate a response, it contracts, and then those chemicals have become used in the area, and the muscle can't contract anymore, or it can't contract to the degree that it was to cause the trigger point. It lowers to more of a normal substance level. So I think that I probably missed that, but that's the idea there, is why we want the twitch.
Any questions on any of that, the procedure, or anything like that? Okay. All right, so back to the outline. Sorry for my little hoopla there. So a little bit of just what I'm going to discuss, and a lot of this we've kind of gotten to, so I'm going to run through this fairly quickly so we have time to do a little demo and you guys can see what it actually looks like. So how we use it in physical therapy, and some of this stuff is things that we've already addressed, but basically the benefits of needling. So what we're looking for after needling is an improvement in range of motion, a decrease in pain, and restoration of function. And so we talked a little bit about how that happens with range of motion, the changes there. You get increased blood flow, decreased banding of the muscle, which means decreased trigger points, and just an increased ability of the muscle to elongate. It's really cool. I'm going to use my mom as an example because that's not a HIPAA violation because she says it's okay. But she had some shoulder dysfunction, rotator cuff, and I was working on her. And I needled her, and I looked at her range of motion. Shoulder flexion is what we call this. And she was probably about 140 degrees. I did her needling. I worked on the back of the rotator cuff, the front of the deltoid, and the bicep. And immediately following, she had a 30 degrees improvement of range of motion in her flexion. So it was right away, really good response in the tissue elasticity, trigger point reduction, decrease in pain. So that was really cool to see. With the decrease in pain, changing the trigger points, changing that spontaneous electrical activity from that trigger point, that really helps to decrease the pain, as well as improving blood flow to that area, like the girls kind of mentioned already. And then restoring function, which that's what we're all about as PTs, is obviously getting you back to what it is that you love to do. So great, my flexion is 170 degrees, but really what matters is now I can put away my clothes in the top cabinet. I can reach and grab a pot out of the cabinet when I'm cooking, things like that. So restoration of function is really important for us. When somebody is coming in, we are identifying what is painful, why is it painful, and how is it limiting your function. So what it is, okay, it's your rotator cuff. Why is it? Because you have these limitations. So it's not just, okay, let's address that tension, kind of what Paige was talking about before, but the tension's there for a reason. So yes, we need to address it, but then we also need to deal with the limitations that's causing the tension in the first place. And then once again, how it's affecting your everyday life. Just treatment of dysfunction as a whole, we look at movement re-education. So we look at how you move through different motions, how you do the things that are bothering you. We do different screening techniques to say, okay, you can't do this, and this is the reasons why, and this is how we can address it. Obviously, a lot of manual therapy, which is kind of how dry needling, we would kind of categorize that as a type of manual therapy, but also mobilizations, manipulations, soft tissue work, similar to what Courtney was talking about, and then also neural mobility. So we're always looking at how the nerves are firing and responding, and if you're having any pain that is a cause of the nerve. One of the things that I really like, and they kind of talked about this at our dry needling course, and I do a lot of selective functional movement assessment. And Gray Cook, one of his big philosophies is you want to reset, reinforce, and reload. So resetting is the things that we're doing manually. That is us putting our hands on you. That is addressing inflammation that you have, reduction in mobility. Those are, the soft tissue techniques that we use, our mobilizations, manual stuff, dry needling, things like that. To change the acute response of whatever is happening. You're having inflammation, you're having pain, whatever the case may be. And then reinforce that by looking at your lifestyle, the things that you're doing, making modifications so that we're making changes, and we're not just addressing this inflammation and then you're going back and doing the exact same thing that's causing the inflammation. Taping techniques, postural education, changing your ergonomics depending on the things that you're doing, maybe having you stop doing something for a while or do more of something else, so things like that. And then the last thing is to reload. And those are the corrective exercises that Paige was really addressing when she was saying, okay, we addressed the tissue, but now we need to do something to get it to respond better and do something to get a better muscle balance, get you to move through different motions better and things like that. So those are kind of the ways that we look at our treatment as far as therapist goes, and dry needling is just kind of a portion of that, similar to what Paige talked about. With the needling, a couple things just afterwards that I always tell patients: make sure you're drinking plenty of fluids. Movement is a good thing. So you don't want to get needled in your hip flexor and then go sit for the next 4 hours, because you're going to get up and it's probably going to be a little sore. We typically, and normally what I tell patients is it's normal to have some symptoms in the muscle similar to you feeling like you worked out. So if you're doing your quads, you might be like, oh man, I feel like I climbed stairs or did a whole bunch of squats.
I loved it when my glutes got needled because I felt like I had got the best workout of my life in and I didn't do a thing.
Yeah, yeah. So, and I noticed that when we got needled, because we'd be needling, and then we'd go over and sit and listen to lecture, and then you got up like an hour later and you're like, oh man, I'm a little sore there. But it was never anything for me that went into the next day. So it's pretty typical, 3 to 4 hours, maybe like later on that afternoon, feel some muscle soreness. But most of the time, it's not something that lasts into the next day where you're like, what's going on here? So, and then don't overdo it. Sometimes you get done and you're like, oh, I feel great, my arms moving awesome, I'm gonna go build a house or something, And obviously that's not the best thing to do. So making sure you're moving, but also being, mindful of the things that you're doing and not overdoing it. Heat or ice is also something that we will use. A lot of times we use that at the end of our treatments. Typically at that point I already know what the patient responds best to. We have some handouts specific on your way out the door if you want to know which is more beneficial, heat or ice for you. Most of the time I recommend ice, but there are occasions that I do recommend heat, and there's some really good information on that too. So if you guys have questions on that or want to know anything about that, then you can grab one of those. And just some case studies, and I just listed a couple things of some people that I have needled over the past few weeks that I've seen pretty good responses with. I hate to just sit here and be like, oh, this is so great, because I've already kind of given you guys a few scenarios of some patients that responded well. I do have a patient that is a long-distance runner, has chronic tightness through her calf, and a lot of Achilles tendonitis pain. And she is one that I've needled quite a bit, and I needle her once a week, and I have for a while now, for probably 6 weeks, so kind of going back to your question there. But she loves it. Afterwards, she's like, my calf just feels like butter. It's so much more relaxed, and she's just had that chronic tension. She runs a lot, she'll run 7 miles the day after I needle her, and so she's, getting a good response and being able to not have to stop in the middle of her runs to stretch because her calf doesn't constantly feel tight. So that's kind of a neat response. I also had a patient that had a knee replacement, but it was 2 years ago, and she had some residual posterior knee pain. And she came in, she was trying to do some different activity, and she was like, I don't know why it still hurts by my knee. And I kind of found that a lot of her dysfunction was coming from her hamstrings. So I did a lot of different soft tissue techniques, but I also needled her hamstring. And I did multiple components of the hamstring, and she did really, really good with it. She's virtually pain-free behind her knee now, but we're working on a lot of her limitations that she had in terms of her strength and function and things like that. And then the last one was my mom. So I kind of already mentioned her and the improvements that she had with the rotator cuff tendonitis. But we have used it all over, from head to toe, basically. Paige and I are both level 1 certified, which means that we are allowed to do certain muscles. And we have to do so many sessions before we can go and get level 2 certified. But most of the areas, like upper limb, lower leg, and then a few areas of the spine are things that we can needle. And so we've used it quite a bit. I think, in 2 months I've done 130 needling sessions, so quite a few, and had some really good responses with it. So it's been pretty cool. A nice little addition to the things that we already do. So any other questions that you guys have before we do a quick demo?
What does insurance company do with this?
It does not cover it at all. So what we did is when we got back, we did a couple weeks where we did needling for our patients, and we just did it free of charge if we were already seeing them as a patient. And so we did that, number one, because we were learning how to do it, and number two, we wanted patients to start to get an idea of this is what it's like, basically. Now it is cash pay only. So here at True PT, we charge $20 a visit for it. We are billing insurance for everything that we're doing outside of the needling, basically. So everything, your treatment session is still going through insurance with the exception of the dry needling. It is a newer technique. I mean, within the state of Kansas, PTs have only been allowed to do this for about a year. I don't know exactly what it is. Now it's more common, like Colorado, they've been doing it for quite a few years there. But I think that once we have more research to kind of back this up, then, Medicare will jump on board, and when Medicare does, then Blue Cross will.
As soon as Medicare picks up,
Yeah.
probably all the other private insurances will.
Yep, so it is cash pay right now. Anybody else? Any other questions? All right, is there any questions online, Nate? Okay, all right. You can go ahead and flip that bad boy off because they don't get a